Hey, awesome. Worried because of all the tough time, all the hard work, and the hardship you have to face right now? You know what? I am not. Because I know that you are tougher, and I know that when you come out of this phase, you will be a better and a tougher person. You will be knowing how to face the future hardship in your life. So take this phase as a transformation for your life. You have to keep reminding yourself that whatever the comfort zone, it may look to you beautiful, it may be very easy for you, but you have to realize that nothing good grows there. The only difference between an ordinary and an extraordinary is the only little extra push which is required by you all right now. So what I am going to teach you here is, you already know that you have to solve last 3 years of Aiims, Neetpg and all other papers anyhow. So you have done it, you are going to revise it, but what I will be teaching you through the course is the previous 5 to 8 years or 10 years of more Aiims question paper in just forms of a statement and the minimum bare required via the small videos. So via this 10-15 minute videos, you will be getting the whole 10 years of the subject wise questions from the Aiims. So without wasting much time and without much ado, we'll move towards it. So if we see the paper of Aiims May 2015, our current subject of discussion, the topic is ENT. So in Aiims May 2015, they asked you about a very hot and very favorite topic from ENT, that is the angiofibroma. So they asked you the most common source of bleeding in a case of nasopharyngeal angiofibroma. So you all know that nasopharyngeal angiofibroma is a very vascular tumor, and the ENT surgeon feared this because of its vascularity, which comes from internal maxillary artery. So this is something you should not mistake. Then another hi-fi and important topic, favorite of everyone, is respiratory papillomatosis. So recurrent respiratory papillomatosis, they have asked topical treatment. So mostly intralesional treatment is there for respiratory papillomatosis in the form of cidofovir. So there are several trials where cidofovir has been used intralesionally in recurrent respiratory papillomatosis. Other thing, friends, you need to remember is it is caused by strains of HPV 6 and 11. So these two strains are the low risk strains, and this causes respiratory recurrent papillomatosis. There are two types of recurrent respiratory papillomatosis. One is juvenile and other is adult onset. So juvenile onset is anything which occurs below the age of 12 years, and we mention as it adult onset when it occurs after the age of 12 years. So this was all which they can ask. Now Kashima operation, they asked that year, is done for. So it is basically an endoscopic cordectomy. So endoscopic laser cordectomy. I will show you the image in last. So be with me for till last, because more images and more detailed discussion, which is very important for you, will be there. So Kashima operation is, what we do is we do laser cordectomy. So if this is your vocal cords, so what we do is we cut the posterior part of the vocal cords in case of bilateral vocal cord palsy, because we need the airway. So to maintain or to give the patient adequate relief from the distress which he or she is having due to bilateral vocal cord palsy, we do endoscopic laser posterior cordectomy, which is called Kashima operation. I will show you the image in the later part of the video. Now, test for eustachian tube malfunction is tympanometry. Now, regarding tympanometry, you should know which all curves are there, as well as what condition causes which type of curve and why. That also I will show you in last, because I want to first revise you all the important previous year questions from Aiims for ENT. Now, true about malignant otitis externa. So with it, what benefit you are getting? You are getting to know the important topic. The first important topic from ENT you have to revise is JNA, juvenile nasal angiofibroma. Second is recurrent respiratory papillomatosis. Now, third topic which you got to know is malignant otitis externa or skull base osteomyelitis or necrotizing otitis externa. So it has various names because it is the endangered disease in ENT. It is called malignant. Do you know why? Not because it is a cancer, but because it is a very serious type of disease which has serious complication. So they have asked in that year is it is caused in diabetic and immunocompromised patient who are more susceptible to the infection. And what happens is granulation tissue is seen on the floor of external auditory canal, and ESR is used for monitoring of the disease. Now, other important things you need to know about this malignant otitis externa is that it is caused by Pseudomonas aeruginosa. Okay, and we use different investigations like technetium scan, gallium scan, indium scan for its diagnosis. So we use here like technetium 99 methylene scan, gallium citrate scan, and what else is how it is treated. So the treatment includes meticulous diabetes control along with oral toileting, systemic and ototopic antimicrobial therapy, and most important is hyperbaric oxygen therapy has a very good role in malignant otitis externa. Surgery is for only local debridement and removal of bony sequestrum. So as you see in osteomyelitis, the bony sequestrum here also you will see. That's why it is called osteomyelitis of ear. So osteomyelitis externa. So we'll move to our primary slides of here. So it is another topic which is very frequent. So you can just know what topic the examiner will ask in your NEET PG 2020 by reading this, or in Aiims 2019 November by reading this. So true about Meniere's disease, another important topic. Electrocochleography is the gold standard investigation, and cement manure decreases giddiness. Now these manure like cement, Apple's, Dix, Hallpike, you all should know. Just Google them, see their image. Already Apple's has been asked, so there is high chances that they are going to ask other manures also. So if you see a child has retained disc battery in the nose, the most appropriate statement is, so battery content might leak resulting in chemical damage of the surrounding tissue was one of the options which was most correct. So that's why we take it as emergency, and we remove it as an emergency procedure if there is any suspect of battery ingestion or anywhere in battery, because it will cause the chemical damage and can cause serious complications like perforation and others. So condition in which topical steroid is not indicated. So any condition like enteroconal polyp whose etiology itself is infection, we don't give topical steroid because it was caused due to infection, and that's why in endoscopic surgery for removal of enteroconal polyp we don't give steroids. A patient presents with traumatic head injury and CSF leak. So CSF leak is another good topic which ENT surgeons like. So the primary treatment is, we see in case of trauma, we try first the conservative therapy, that is we will wait for 3 to 5 days, we will wait for its spontaneous resolution. Otherwise we will go for the recommended or the standard of therapy is now endoscopic. So we'll do the endoscopic CSF repair if it is CSF rhinorrhea, and in case of otorrhea we'll open the mastoid, and based upon the investigation like MRI, cystonogram and others, we'll identify the site leak and close the leak. Complication of adenoidectomy includes retropharyngeal abscess, cervical spine injury, and velopharyngeal insufficiency, as well as hypernasality. So it was very common question. Now, most common cause of vocal cord palsy will be a malignant disease. Other causes is iatrogenic, like a lot of thyroid surgeries are being done, so those can also cause the vocal cord palsy if the surgeon injures the nerves like recurrent laryngeal nerve and the superior part of the nerve. So this also causes the vocal cord palsy, but the most common is malignant disease. An elderly man presents with T3N0 laryngeal carcinoma. It will be managed by concurrent chemoradiotherapy. Now, laryngeal carcinoma is another very hot topic you need to revise, and you should know the staging and treatment. So for your knowledge, I will tell you to go through the eighth edition of the TNM staging, because the 7th is now outdated. You should know the 8th staging system, where the T3 for glottic laryngeal carcinoma indicates vocal cord fixation or invasion of paraglottic space or thyroid cartilage cortex. So any tumor which is causing vocal cord fixation will automatically cause a T3 lesion, or in any tumor causing paraglottic space invasion or involving thyroid cartilage. PT1 was, which is limited to one vocal cord, that is may involve the anterior or posterior commissure with normal mobility. T2 was tumor extending to supraglottis or subglottis with impaired vocal cord mobility. So here the vocal cord mobility is impaired but not fixed, but in T3 it is fixed, and here we will need both chemo and radiotherapy. That's why concurrent chemoradiotherapy. So you need to go through the management of laryngeal carcinoma again. Now, Aiims May 2014, the screening test for high-risk neonate in ICU for suspected hearing loss is otoacoustic emission. So this topic is one topic which Aiims people are very fond of asking. So you should know the types of otoacoustic emission and everything regarding this. The wave 5 in BERA represents activity in. So you should also know the different waves and what they significance. So here the wave 5 represent lateral lemniscus. Now in stapedectomy, they are asking what all parts of stapes are, or what all parts are resected. So we do stapes how? So we'll do the cutting of stapedial ligament or the stapedial tendon, as well as we cut the anterior crura of stapes as well as the posterior crura of stapes to free up the suprastructure of stapes and remove it for the stapedectomy. Although now stapedotomy is done and not stapedectomy. Now, part of cochlear implant implanted during surgery is receiver stimulator. Now, cochlear implant, brainstem implant, so these are the advanced ENT things which they always ask. So you should expect this advanced type of things in your exam, in always a must type. So you should know. We'll discuss this cochlear implant in little detail because your examiner wants you to know these. Now, if you ask me who is the father, so if you ask me to whom you will give credits for this cochlear implant, so I will say that this Dr. William H. House is the inventor of cochlear implant along with John Doyle and James Doyle. So he was the inventor. Another important question regarding cochlear implant is what is the selection criteria? So in children, child above than 12 months and below 7 years in prelingually deaf children, at birth cochlea is fully formed but the auditory pathway is not. So for auditory pathway, to form. The bare minimum is child above 12 months and below 7 years. Post-lingual deaf with no age limit. Degree of deafness should be very profound, that is greater than 90 decibel sensory neural hearing loss, and the response to hearing aid, that is before cochlear implant you should always give a hearing aid trial. So even in cochlear implant patient we do a hearing aid trial, and if it fails we go for cochlear implant. So in those who do not benefit from hearing aid, at least 3 to 6 months of use we go for hearing implant. And the important thing is there should be absence of contraindication, and for that you should know what are the contraindication. So any cochlear aplasia absent of cochlear nerve are the absolute contraindication, because our purpose is to stimulate the cochlear nerve by placing the electrodes. Now if there is no cochlea or if there is no cochlear nerve, we cannot stimulate it, and then we have to go for a brain stem implant or any other modality, but not a cochlear implant. In adults, the selection criteria is severe or profound hearing loss with a deafness of 70 decibel or more, little or no benefit from hearing aid, and aided score on open sentence test of less than 50%, no evidence of central auditory lesion, and no medical or radiological contraindication. The third question which they ask is parts of cochlear implant. So you should know that it consists of two parts, external and internal. The external has microphone, speech processor, transmitter. The internal has receiver and stimulator, and an array of up to 22 electrodes. So this is the thing, you can see the external portion and the internal portion, external portion parts and the internal portion parts. So they may give you the diagram and ask you what all the parts, which this part denotes which part of the cochlear implant. So electrode array are also two types, which is less important for you, that is extracochlear and the intracochlear electrode. And the length of human cochlea, which is another MCQ, is 33 to 36 millimeter. Your NB people are very fond of asking these MCQs. So 33 to 36 millimeter. The fourth question they will ask is regarding this vaccination. So there are two vaccinations which are available for cochlear implant patients, that is pneumococcal polysaccharide vaccine 23 and 13. So these two have to be kept in mind before you do a cochlear implant. So children below 2 years receiving implant should receive PCV 13, and children greater than 2 years should receive PCV 23. So easy to remember. Who are greater than 2 years will receive the greater number, that is 23 strain, and who are smaller, less than 2 years, will receive the smaller one, that is 13. Okay, so child planned for implant should be up to date with the age of the vaccination, and this vaccination should be done at least or greater than 2 weeks before the surgery. So all children should receive 3 doses of pneumococcal conjugate vaccine before the age of 1. And the other criteria you should note, these 3 criteria are also important, so note them up. So how they are done by different techniques. So this is a C-shaped incision. There are also different incision, but the main thing which I wanted to tell you by this figure is this is the post-oral approach for cochlear implant. Okay, and what the surgeon do is they make a cochleostomy near the round window. So round window niche is clearly seen after you do the mastoidectomy and go through the facial recess approach. The round window niche will be seen in the middle ear, and then you create a cochleostomy, that is a separate opening inside the cochlea, and the size of cochleostomy will be from 0.8 to 1.2 millimeter in diameter. So here you can see the round window. This one is the round window and this is a cochleostomy. So they may give you a picture showing you an electrode going into the cochleostomy, and they may ask you what is this structure. So this is the electrode. I'll show you. This is the electrode and this is the cochleostomy where it is going. So the important question which they have already asked is where you insert this electrode. So this answer you will write me in the comment. I want to know how many of you know this answer, because this is a repeat question, and I expect you that you know all the repeats. Another important method of doing a cochlear implant is Virya technique. So this Virya technique, what's difference is it is a non-mastoidectomy technique. So it is a newer technique. The Aiims people may ask you this. The Virya technique, where you go through the canal only, you go through the endoral route and a tunnel is created in the posterior canal wall. So what benefit we get is a faster healing, easier fitting of the processor, and minimal trauma to the facial nerve. So here we are not opening the mastoid cavity, less time, easy to do. So this is Virya technique, and here you can see a Virya technique in process. So this is your EAC, and they are creating a tunnel in the posterior canal wall. And this is a beautiful X-ray showing you a bilateral cochlear implant in place, and here you can see a spiral, this electrode going into the cochlea. This is the spiral turn you can see here. So this is a X-ray showing you the cochlear implant. What post-op complication can occur? So it can cause facial nerve injury, it can cause flap necrosis. The most serious complication, flap necrosis, if occurs, you have to remove the cochlear implant. And the most common cause of displacement of the electrode is movement of electrode array while you are drilling off. CSF fluid leak may also occur. We have already discussed the tympanometry. So I was telling you should know, you should be able to recognize the different curves. So this is the AS type of curve. This one is the AS type of curve, the yellow one. A is the normal. AD is this one where you get a hypermobile, that is the disarticulated, like in case of ossicular disruption. B is this curve which is going just right, blue one, and C is this one where you get a negative pressure. Now in what condition you get these type of curves? So type A is the normal one, type AD is ossicular discontinuity. As I was saying, the compliance get increased here and you get a hypermobile ossicles. So this is ADAS will be in otosclerosis where you get less mobility than normal, or tympanic membrane scarring like tympanosclerosis, etc. B type where you don't get any pressure, response or difference, that is the in otitis media effusion, means the tympanic membrane is not moving. Occluded cerumen, probe against the canal, head trauma, otosclerosis, cholesteatoma. Although for otosclerosis AS is the typical one, and C is where you get a negative, that is eustachian tube dysfunction. So this was all about the tympanometry curve, and the topic which I will discuss is Kashima, where you see a posterior endoscopic cordectomy. So this is basically showing you the Kashima operation for giving the airway, adequate airway to the patient who is having stridor or respiratory distress due to the bilateral vocal cord palsy. Now we'll move to our parent slide, that is this one. So I have discussed a lot. I think it's already 20-minute video. You will be getting the next part of this in your course via email, that is the PGMEE Hys mastery course. So I will recommend you to please enroll. The money is nothing as compared to the value you will be getting and the benefit you will be getting. So this is Dr. Shivam signing off. Stay happy, stay motivated, and do whatever you want to do. Thank you.